We are live now, sir.
Okay. Good evening to all participants. Today we are going to discuss about a vaccine, a new vaccine which has come to counter rabies. So we will discuss about its why it is better than the existing one. Okay. So first of all, we all know about the rabies. Rabies is a viral-borne disease which occurs due to the bite of wild animals, most commonly because of the stray dogs. It can occur because of the bite of cat, monkeys, or any wild animal. So it generally kills around 59,000 of human deaths annually, and it is highest in the India. And the WHO report that this dog bite is responsible for more than 97% of the rabies cases, and it causes. Okay. So India India has 20,000 human deaths every year.
हेलो, मेरी आवाज आ रही है सर? Very good evening, all the delegates gathered here today throughout webinar for discussion on rabies and anti-rabies vaccine. I thank each and every one for you for your intimate presence at this occasion. The respected doctor, as you know, that rabies is how much fatal for us, and we all are aware that there is only prevention, not cure, so need to improve awareness level at every end. Now I should like to welcome our respected speaker, Dr. Piyush Raj sir, who has a renowned physician and always care about the prevention from rabies and having very executive knowledge and experience about the all kinds of vaccines. So now I am going to hand over the session to Dr. Piyush Raj sir. Thank you, sir.
Thank you. So we are going to start the session. As you know, the session is going to discuss about the new vaccine which has come to deal with the rabies. And we all know that rabies is a viral-borne disease, and it occurs secondly to the bite of animal bite, and secondly to the bite from dogs. It can occur because of the bite of bats also, cat, or other wild animals. So generally, rabies kills around 59,000 people globally every year. And WHO they have got check it. Okay. We have to start from the beginning. एक slide और. So what we have discussed earlier, that we discussed about the rabies. What is the epidemiological graph? So rabies kills around 60,000 humans annually, and 60% of the rabies death is in Asia itself. 90% of the death occurs because of the bite of the stray dog, the dog bite, and 91% of deaths occur in the rural area. So what we'll do, there's at every 9 minutes, a person dies because of the rabies. So after the bite, what is the current mechanism? Current mechanism, what can we do after the bite? Initially, we can wash the wound, we decrease the viral load, and we decrease the entry of the virus. It can be done by washing the wound with soap and running tap water. It should be done for at least 15 minutes. After that, we can go for the active immunization, which is vaccine. WHO prescribes vaccine, which is 5 doses. And for that category, we divide the categories. According to that, we do the wound care. And apart from that, there is passive immunization, in which we give immunoglobulin. So what are the current challenges for the post-exposure prophylaxis? There is non-compliance of the patient. We will discuss this greatly in the coming slides. And the current rabies vaccine is cell culture vaccine. And other type of vaccine is inactivated vaccine, which is age-old, around 15 years old technology. Apart from that, there is these vaccines has inconsistency in the potency, and they have got questionable stability. Their availability is short, and they can precipitate adverse events also. So for compliance, what is we mean by compliance? Patient who receives the full course of rabies vaccine is said to be compliant because he has received the scheduled doses of ARV on the recommended dose. Delayed compliance is those patients who has completed the scheduled dose of ARV within 16 days but deactivated from the scheduled regimen. And there are non-compliant patients who take at least 1 dose of anti-rabies vaccine after the annual bite, but not completed all the scheduled doses. So rabies post-exposure prophylaxis in routine practice, if we see a small study, in a travel clinic, a retrospective analysis was done. Around 110 patients were examined who has received the 4 doses of post-exposure prophylaxis, and there were a bit shortcoming. There was late initiation of the rabies in travelers, and administration of immunoglobulin was there done, and the antibody levels found to be short, even around 7% of the patients, even after the 4 doses of vaccines. So the conclusion is patient always don't receive the optimal rabies post-exposure prophylaxis under the real life conditions, and a significant portion of patients did not develop the adequate antibody level even after the 4 doses of vaccines. So the non-compliance of even after the 5 doses, the key is that there is so much number of doses, so patients could not afford to come on the required dates to have the vaccine. So hospital, if we see in the long term, then we see that the reason of death is due to the lack of the administration of rabies immunoglobulin or poor compliance of the vaccinations. So compliance to post-exposure prophylaxis among animal bite patients, we have done a study on a hospital-based epidemiological study was done. And it shows that around 53% were non-compliant for the full course of ARV. It means that 53% of patients did not complete the full course of ARV, which consists of 5 doses. So compliance to anti-rabies vaccination in post-exposure prophylaxis. At Bangalore, we have done the study in a municipal corporation hospital. Around 215 patients were examined, and 1 dose of rabies vaccine was administered intramuscularly on around 5 days at the prescribed dosing schedule. They also measures the constants for compliance to the complete course. So the compliance rate for IM rabies vaccination is around 60%. So why the patient don't complete the full course of the therapy? That is because it interferes with their day-to-day activities. Some are daily workers, so there is a chance of loss of wages if he comes to the hospital. Around 50% fear of that. Hospital timings coincide with the school timings. The distance to the hospital, the cost related to the transportation, and the forgotten dates. So these hinders in the completion of the required dosing. So if we see the history of the evolution of the rabies vaccine, we earlier when Louis Pasteur uh, discovered about the benefits of the immunization, uh, soon after that, live attenuated vaccine, which primarily grow in the spinal cord, were discovered. And in around 1911, inactivated vaccine, which is derived from the brain tissues, they were developed. Earlier, it consists of as many as 31 injections were required to induce the immunogenicity, which later on decreased to 14 injection. When we were a child, we used to know that after the animal bite, we have to take 14 injection in the stomach. We used to discuss that while playing with the dogs. So nowadays we go for after the cell culture, and currently these type of injections are in practice and is approved by WHO, in which cell culture is used, and we take around 0.5 to 1 ml of the injection and 5 doses. The dosing schedule is on the due date, the 0 date, 0, 3, 7, 14 and 28. So this is the content. Uh, the non-compliance lead to evaluation in the treatment design from 31 doses to the 5 doses, and this trend is going on. So what is the unmet medical need? So we are introducing a novel vaccine with simple and shorter regimen. The novel 3-dose recombinant rabies G protein vaccine. It is a subunit vaccine prepared from virus-like protein, and these virus-like protein is a nanoparticle which goes and induces the immunogenicity. It is prepared by virus-like protein platform technology, and first vaccination with as less as 3 doses schedule is just needed. We complete the whole dosing schedule within a week. So technically, it has got a better compliance because of the easy to flow of regimen and less frequent visit to the hospital. It is convenient, it is ready to use, and no reconstitution is needed. So what is VLP technology? Actually, it is a very recent advancement in which we use the newer, most cost-effective vaccines, which is required in a fewer doses. It is a breakthrough achievement, and it based on the recombinant nanoparticle-based rabies G protein vaccine. So only 3 doses regimen is required, one is 037. So the native virus, we take uh, virus-like protein from the vaccine and use as a generator of the immunogenicity. The G protein, which is difficult to stabilize, the G protein isolation was done with the VLP, and it is purified and stabilized. After that, it is introduced in the body, which causes the rise of the immunogenicity and proliferate the immune responses within the body. So if we see the trial in the clinical phase 2 trial, so we randomized the trial and we divided the study design was done in around 4 groups. There is two dosing schedule were given. One is 10 microgram and another one is 50 microgram. And if we see the reaction, so there was no serious adverse effect is noted. The anaphylactic reaction was reported, which were mild, such as headache, or there's no very frequent musculoskeletal or connective tissue disorder. Okay, general malaise was just noted. So if we see the clinical study phase 3rd, so the objective is to establish that it is non-inferior to the novel 3. The newer one is non-inferior to the what vaccine is existing right now. So a multi-centric open level assessor blind center specific block was randomized and parallel design. Phase 3 clinical study was conducted among 800 patients. The eligible subjects were randomized in 2:1 ratio for the recombinant rabies G protein vaccine and the reference vaccine. Subjects in recombinant rabies G protein vaccine arm received 3 doses of the vaccine on days 0, 3, and 7, while subjects in the reference vaccine arm received 5 doses of WHO pre-qualified vaccine on day 0, 3rd, 7th, 14th, and 28th. So if we discuss the results, the efficacy as per WHO recommendations, the rabies virus neutralizing antibody titer was 0.5 international unit per milliliter is considered as seroprotective against rabies. The seroprotection on day 14 was measured and found to be 99.24% and 97.72% in the recombinant rabies G protein vaccine arm and the reference vaccine arm respectively. The difference was statistically insignificant, and likewise on day 42, the 98.69% in the subjects of the test vaccine arm and 100% in the reference vaccine were seropositive. The difference is also statistically non-significant. If we discuss about the safety of the vaccine, around 10% of the subjects in recombinant rabies G protein vaccine arm and around 18% or 17% subjects in the reference arm reported adverse effect. The adverse effects are very mild to moderate in nature and it resolved without any complications. The most frequent observed local adverse effects were pain, redness, and swelling at the injection site. The systemic adverse effect were fever, headache, ear pain, urticaria, joint pain, and the nausea. None of the study subjects in either group discontinued the vaccination course due to the adverse effect, and no death or serious adverse effect or anaphylactic reactions were absorbed during the entire study. The compliance to complete the course of the vaccination was 99.5% among the 800 participants. All the study subjects were healthy up to the date 365 in the both arms. So if we conclude the study, we find that so in the conclusion, we can say that the novel 3-dose recombinant rabies G protein vaccine was found to be safe and immunogenic and was comparable to 5 doses of WHO pre-qualified vaccine in simulated post-exposure prophylaxis. The reduced number of vaccine doses leads to the reduction in the number of visits and travel costs, as well as the increase in the compliance, which is important to prevent rabies and ultimately help in eliminating dog-mediated human rabies by 2030. So there is mainly three conclusions. First, the new vaccine is non-inferior to the reference vaccine. There is also less adverse effect compared with the reference vaccine, and novel 3 doses were found to be safe, immunogenic, and was comparable to the existing 5 doses WHO pre-qualified vaccine. And now some awards, which has the Innovation Pharma of the Year and for the Catalan, and it receives. So thank you. This is the end of the presentation. Okay, any questions? You are free to ask. So we'll finish the.
Once again, sir. Thank you, sir, for giving the very important time. First of all many thanks for Dr. Piyush Raj sir for their valuable speech, which was very presentable and message is clear. The 3 dose therapies is more effective as compared to 5 dose vaccine available in the market. On behalf of Cadila Pharmaceuticals and Travis, I thank you for all for tracking time work from your busy schedules to be a part of this webinar. Your presence has currently enriched and elevated the style of this meeting. Kindly continue your valuable support for Travis, which is the first time 3 dose anti-rabies vaccine. Thank you, sir. Sir, my company, sir, respected sir. I know very well about Travis. Travis is the most important vaccine is involved in India. So we all Indian proud feel for Travis. So kindly request to you, please support me and please prescribe your patient Travis. Travis is a very simple vaccine and 3 doses vaccine. Other vaccine 5 doses, but our Travis is 3 doses. Thank you, sir. About Travis. Travis is the most important vaccine involved in India. So we all Indian proud for Travis. So kindly requesting you, please support me and please prescribe your patient Travis. Travis is a very simple vaccine and 3 doses vaccine. Other vaccine 5 doses, but our Travis is 3 doses. Thank you, sir.
Thank you.
Travis is the most important vaccine involved in India. So we all Indian proud for Travis. So kindly request you, please support me and please prescribe your patient Travis. Travis is a very simple vaccine and 3 doses vaccine. Other vaccine 5 doses, but our Travis is 3 doses. Thank you, sir. Okay. Thank you, sir. Log out कर दीजिए. Okay, one second, sir.
मैडम चली गई.
Sir, my small compliments for you, Travis.
Hello. Hello. Hello.
Okay, thank you, sir, for support. Sir, one second, sir, कुछ आपसे बात मैंने किया था, sir.